So that gives you brief introduction about the bones that are present on the upper limb. Okay. So any dissection starts. So any dissection start with skin. Am I right? First layer is skin. So skin should be supplied by what type of nerve? Skin. It is the organ of sensation. Am I right? Cutaneous is sensation. Cutaneous is sensation. So to anything start with any region, you should know the cutaneous innervation of that particular organ. If you take this as an upper limb, this is arm, this is forearm. Am I right? As you said, this is the medial border which contains medialitus, lateralis, radius. Here, what is the bone you expect? Humerus. The bone is humerus. So easy to remember the cutaneous innervation. Okay. What is this bone prominence present on your body? What is this muscle where we give intramuscular injection? Deltoid. So this area is supplied by C4. C4. We'll trace the origin of each nerve later when we do brachial plexus. Time being, in general, you remember the skin, I'm telling the cutaneous innervation of the area. The skin over this area, over the deltoid is supplied by C4 fiber. You said lateral and medial, am I right? So to the arm, this is lateral, this is medial. So this is the lateral side of your arm, am I right? Here it is C4, here it is C5. The next fiber is C5. Still you descend down. Lateral aspect of forearm. C6. You understand, right? C4, C5, C6. Come to the palm. C7. Palm it is C7. Now you ascend up. What is this area? Medial aspect of arm or forearm? Forearm. C4, C5, am I visible? C4, C5, C6, C7. Next is C8. In order, C4, C5, C6, C7, C8. You should remember the nerve alone. Site, it is very easy, right? Skin over the deltoid. Lateral aspect of arm. Lateral aspect of forearm. Center of palm. Medial aspect of forearm, medial aspect of arm. What is this area called as? Armpit, right? The area between the shoulder girdle and the clavicle is armpit. So skin over the armpit is supplied by T2. C4, C5, C6, C7, C8, T1, T2. You understand, right? So that completes cutaneous innervation. You know the area, what are all the nerves? That is important for MCQ, area of distribution of cutaneous nerves. But these nerves are arising from brachial plexus. We'll trace from where it comes when we do the brachial plexus. So important salient points of osteology. I'm not going in detail. What is this bone called as? Collarbone. The bone is collarbone. Only bone which is present horizontally. Yesterday we discussed long bone. Am I right? Long bone should have an upper end, lower end, and shaft. Yesterday we discussed. Am I right? So only bone that is present on the body, long bone horizontally, is clavicle. Am I right? It doesn't have medullary cavity. It doesn't have medullary cavity. No medullary cavity. So what type of ossification it can be? It is not cartilaginous. So it is membranous ossification. It is membranous ossification. This is the medial side. This is the lateral side. The medial end articulates with the manubrium sternum. The lateral end articulates with the scapula. If it articulates scapula here, the name of the joint is, what is the name of the joint? The joint acromioclavicular joint. Acromioclavicular joint. It articulates with the acromioclavicular, so it is the acromioclavicular joint. Here it articulates with the sternum. So sternoclavicular joint. Sternoclavicular joint. Sternoclavicular joint. So it ossifies from membrane. Do week of intrauterine life? It's primary center and secondary center, right? What is primary? What is secondary? Primary occurs intrauterine life, secondary after the birth. So here you will be having the secondary center. So age of fusion to some bones you have to remember, not to all the bones, which are all important for MCQ. That alone we'll discuss. Whole of the bone in the body you cannot remember. Okay, this is very important, so I am telling you. So it has two primary center, which later fuses to form. I think the PowerPoint will be shared to you. Am I right? If you want, you can take down this point. If not, you just mention the PowerPoint number 3 like that. Okay. Don't waste your time on writing. Whatever is not given on the PowerPoint, that alone you take down. They'll be converting this to USB and sharing. Okay. So secondary center, again 6th year and 21st year. So what you have to remember is, the bone is divided into a medial 2/3 and lateral 1/3. Now you see on the picture there is cross change in curvature of the medial 2/3 and lateral 1/3. Am I right? So that is the commonest site of fracture of clavicle. So how can the fracture can occur on clavicle? What is the one important possible cause? Fall, outstretch and fall on an outstretched hand, you get fracture. So the nerve piercing the clavicle is supraclavicular nerve. Supraclavicular nerve, as the name indicates, supra is above the clavicle, a nerve is present that is called as supraclavicular nerve. An artery is related to clavicle called as subclavian artery. Subclavian, so many muscles which are attached. I am not going with those details. Okay, you know what are all the articulation? Medially clavicular. It articulates the acromion forming acromioclavicular joint, and you remember it ossifies from membranous ossification. Just two primary centers, and it is divided into medial 2/3 and lateral 1/3. So that is the commonest site. Since there is change of curvature, it is the commonest site of fracture. And the nerve piercing the clavicle is supraclavicular nerve, and the artery related is. So on the interior surface, you can see a subclavian groove, where the artery related is subclavian artery. Subclavian artery. At some time, clavicle can be absent. Both the clavicle can be absent. That condition is called as this you have to remember. In which condition means membranous ossification is not happening. It is a congenital anomaly called as craniocleidodysplasia. Commonest fracture on the children again is green stick fracture. Why so? What is green stick fracture? What is fracture? Any anatomical discontinuity of the bone is called as fracture. Fracture should involve periosteum. Unless otherwise periosteum is involved, we don't involve it as fracture. It is only fragment dislocation. Anatomical dislocation along with periosteum represent it as fracture. So what occurs in green stick? Periosteum is involved or not? It is not well developed, right? I said it is common for the children. So only bony fragments is present. The periosteum will not be involved on the green stick fracture. Up to this, you remember regarding clavicle. So that is the first bone to ossify in the body too. So during normal routine prenatal scan, presence of clavicle represents 3 to 4 weeks of intrauterine life. It corresponds to, so when you do an ultrasound during prenatal checkup, when you look for a membranous thing over the shoulder, that represents the clavicle. That is the first bone to develop in the body. It is again a very peculiar one. It is present horizontally, no medullary cavity, develops from membrane to primary center. Apart from that, that is first bone to develop in the body. Okay, it is again a key sign to defeat age in the intrauterine life. These are clinically very important. Okay, next I'm going with the humerus, which is the bone of arm, which has an, so what type of bone it is? Long bone or short bone? Long bone. Long bone should have an upper end, lower end, shaft. On the upper end, it articulates with the scapula to forming shoulder joint, right? So what type of joint it can be? Ball and variety is ball and socket. Yesterday we discussed it should have a ball. One more ball and socket is hip joint. So it articulates with the scapula, forming shoulder joint. Type of joint is ball and socket. Synovial. It is covered by fibrous capsule. So it is synovial ball and socket joint. And there are two projections here, right? One is greater tubercle, other one is lesser tubercle. And this area is called as bicipital groove. Bicipital groove. See the surface. You can see one more groove. That groove is called as radial groove. That groove is called as radial groove, which lodges radial nerve and profunda femoris artery. Profunda brachial artery. We will discuss along with the triangles. Time being, remember the bony structures. And regarding lower end, medial epicondyle, lateral epicondyle. This is trochlea. This is capitulum. Trochlea, capitulum. This is coronoid fossa. Not process, this is fossa. Process is present on ulna. This is radial fossa. You understand, right? Medial epicondyle, lateral epicondyle. Trochlea articulate with the upper end of ulna. Capitulum articulate with the upper end of radius, forming elbow joint. Then why this two fossa should be present? Coronoid fossa, as he said, there is one more projection called as coronoid process. So when you flex your forearm, the coronoid process will come and lodge on the coronoid fossa of humerus. Again, when you flex, the head of the radius will come and lodge on the fossa of humerus. Again, if you flex, am I right? When you flex, it is coming like this. Now you are extending your elbow. Now what occurs? Normal articulation is present. Trochlea is articulating with the ulna and capitulum is articulating with the radius. What occurs on the posterior aspect? There is one fossa on the posterior aspect called as olecranon fossa, which lodges the olecranon process of ulna in full extension. Is it clear? Only on full extension, olecranon process of ulna is lodging on the olecranon fossa of humerus. If you flex, the olecranon fossa will glide over. So what type of joint we discussed? This elbow joint is an example of hinge joint. Very good. It is an example of hinge joint. Now you should remember this neck of the humerus is called as anatomical neck, and this neck, sorry, this is surgical neck and this is anatomical neck. There are two necks on the humerus. This is anatomical neck, this is surgical neck. Anatomical neck and surgical neck. So the structure related, there are three nerves which are on contact with the humerus. What is related to the surgical neck is axillary nerve. What is related to the radial groove is radial nerve. What is present behind the medial epicondyle is ulnar nerve. So three nerves are in close approximation with the humerus. So any fracture of the humerus can compress any three of the nerves, and the neuroclinical manifestation varies depending upon the which nerve, which side. The clinical manifestation is reflected over the arm or forearm or on the hand. That's the reason why we read the course of the nerve in detail where they are supplying during fracture. Is it clear? So three nerves are close approximation to the humerus, axillary nerve on the surgical neck, radial nerve on the radial groove, ulnar nerve behind the medial epicondyle. Up to this you are clear, am I right? So it ossifies from, there are so many centers. I think this you can skip off. Okay, just you remember the center for shaft alone, it is on 7th to 8th week. Again, each bone, as we discussed, what foramen will be present for its blood supply, how the bone is nourished, nutrient artery. So it contains nutrient artery. So what would be the artery of the arm? Which artery we are using for recording that pressure? Brachial artery. It is brachial artery. So branch from brachial artery will enter into the humerus to supply its nourishment. Being long bone, medullary cavity will be present, right? So one more thing you have to remember is angle of torsion. It is given on your PDF also, that will be shared. What is angle of torsion? The angle formed by the superimposition of the upper end and lower end of the humerus is called as angle of torsion, which is 163 degree. Angle of torsion. These are all in MCQs. One more thing is carrying angle. What is carrying angle? The angle formed by the arm and the forearm. Here you get an angle, right? This angle is called as carrying angle, which is 12 to 14 degree. 12 to 14. Angle of torsion is formed by the upper and lower end of humerus as such. It is 160. This values you have to memorize, no other options. You have to remember all those things. It will be shared on the from the notes it is given. Okay. What is carrying angle? The angle formed by the arm and forearm. Okay. This angle is very important when you go for, when it is important. A patient is coming with a fracture of radius and ulna, right? We do splint, I mean, right, plaster of Paris to be applied as a temporary method. Apart from open reduction, we apply POP. Am I right? By the time the angle to be corrected. If not, malunion is possible. If not, that there is change in the architecture of the forearm is possible. So by the time you take an X-ray, you have to assess the angle, how much it has been default, make the angle as much possible. Again, after treatment, apart from complication, you have to look for the carrying angle and the angle formed by the upper and the lower, superimposition angle of the upper and lower end of humerus to be considered. Okay. So all the three humerus, axillary nerve, radial nerve, and medial nerve. You know the articulation, right? Above it is ball and socket. Here it is hinge. So, are you aware of pre-axial border, post-axial border? On the arm, this is flexor compartment. On the upper limb, here it is called as flexor compartment. The lower limb, it is actually opposite. Am I right? Here it is called as extensor compartment. It is because of the rotation of the limb buds during development. Normally, if here it is flexor, then it is flexor. Am I right? But it is not so. Limb rotates, thereby here the extensor compartment posteriorly and flexor comes anteriorly. That's the reason why there it is extensor, here it is flexor. So this border is post-axial border. This border is pre-axial border. What is related to ulna is pre-axial border. What is related to the radius is post-axial border. Next, what you have to remember is regarding the lower end of, you can see, right? The olecranon is lodging on the olecranon fossa, right? One ligament you should know at this site. The ligament at this site is annular ligament, which encircles annular ligament. Annular ligament. What is the ligament which is holding the elbow joint is annular ligament. Annular ligament. A-N-N-U-L-A-R. Annular ligament. Shall I proceed? Yes. See on this. This is the inferior surface of radius. On this, this is the anterior view. You cannot see the radius as such. Am I right? If you take the lower end of the radius, on the posterior surface, there is a tubercle called as dorsal tubercle of Lister. Lister tubercle. Lister tubercle. Dorsal tubercle of Lister. If this is medial, this is lateral. Dorsal tubercle of Lister. A tendon crosses medially, two tendons crosses laterally. The tendon present medially is extensor pollicis longus. The tendon crossing laterally is extensor carpi radialis brevis and extensor carpi radialis longus. This relation you should remember. Dorsal tubercle is a feature of posterior surface of radius, which is related to the following tendons, one tendon medially and two tendons laterally. The tendon related medially is extensor pollicis longus which is present laterally is extensa carpi radialis longus and extensa carpi radialis brevis. Now you concentrate on the inferior surface. Radii should articulate with carpal bone, am I right? Two carpal bone forming wrist joint. Wrist joint is formed by ulna will not take part on the wrist joint. Okay, but the radius and ulna are articulating, am I right? This is called as superior radioulnar joint. This is called as inferior radioulnar joint. Inferior radioulnar joint is an example of what type of joint? Yesterday we discussed syndesmosis. It is connected by a fibrous sheath or by ligament, so it is called as syndesmosis. Upper end of radius and ulna is articulating with the humerus forming elbow joint. Upper end of radius and ulna is articulating each other forming superior radioulnar joint. Upper end of lower end articulates forming inferior radioulnar joint. Now the lower end of the radius is articulating with carpal bone, 2 in number alone, not whole of the carpal bone. Remember the carpal bone name alone. This is proximal. What is towards the elbow is proximal. What is away is distal. Is it clear? So you get 2 rows. I said how many bones? Totally 8 bones. Number 1 is scaphoid. You are aware of the mnemonics. What is same thing, right? Try to catch air. She is scaphoid. She look, right? She look too pretty. T. What is S? So this 2 proximal bone, lateral 2 bones articulate with the inferior surface of the radius forming wrist joint. Is it clear? We'll come to the carpal bones later. Now remember this you have to remember this mnemonics. Primary center for radius and ulna occurs by 8th week of intrauterine life, and secondary center, remember this mnemonics, crypto. Okay, capital M 1 year. You can't leave the radius alone. Rest of the things you omit. Radius and olecranon. Okay, you remember this dictum 1, 3, 5, 7, 9 and 11. Am I right? It is very easy to remember. Capital M, radius, medial condyle, trochlea, olecranon, lateral epicondyle, right? So remember this dictum crypto 1, 3, 5, 7, 9 and 11. What is related to radius and ulna is 3 and 9. Lower end. So remember the second on this order the fusion takes place. The fusion occurs first on the upper end of radius, next on the lower end of radius, next on the upper end of ulna, next on the lower end of ulna, right? This is one. This is clear, right? Now you go with the carpal bones. She looked too pretty. Try to catch. So she is scaphoid, lunate, triquetral, pisiform. Try to mid-axillary line. Remember this area is covered by the skin. What muscle you expect deep to the breast? Pectoralis major muscle. Lower down external oblique muscle. Lateralis serratus anterior. So 3 muscles are related to the breast. Pectoralis major, external oblique, serratus anterior. That we call it as mammary bed. 3 muscles which forms the mammary bed. Nipple areola. What is it? Areola, dark pigmented area over the breast. The breast is called as nipple, which contains sebaceous gland. Which is you get some tubercle called as tubercles of Montogometry. Okay. Now what is axillary tail of Spence? A small part of the on this the interior will come to it. A small extension of the breast is invading inside the pectoralis major deep inside. Am I right? You get some tail-like structure. Am I right? This is related to the apical group of axillary group of lymph node that is called as axillary tail of Spence. Axillary tail of Spence. Now you see on this picture, this muscle is delta major. You get a groove here, right? That is called as deltopectoral groove. The groove is called as deltopectoral groove. Again, you see on the picture there one more vein which has been enlarged here. That is called as cephalic vein. So structure enlarged on the deltopectoral groove is groove between this major muscle and deltoid muscle. So name of the groove is deltopectoral groove. The structure enlarged is cephalic vein. As we already discussed on how many muscles? 3 muscles. What is retromammary space? The space behind the. What is retro is? Behind us. Behind. So behind the breast, a space is present that is called as retromammary space. Is it clear? So as you see the structure of the breast, it consists of fatty substance, glandular substance. Alright, you get some fat as well as glandular structures. Am I right? So those glandular structure is called as lactiferous duct. That we call it as lactiferous duct. Duct. And what is the fiber which is holding the breast on its position is a fibrostroma. That we call it as fibrous stroma, which holds the breast in position and gives a shape to the breast. That we call it as ligament of Cooper. Ligament of Cooper. As age advances, the fibrous tissue will be less in a female. Am I right? As age, that's the reason why the shape of the breast varies with age. The main factor is suspensory ligament of Cooper. It is, that we call it as suspensory ligament. Suspensory ligament of Cooper. The fibrous stroma which is holding the breast in position is called as suspensory ligament of Cooper. This we already discussed. Nipple and areola, blood supply, right? This is internal thoracic artery which is running on, this is sternum, right? This bone is sternum. Running on either side, this is internal thoracic artery. Internal thoracic artery. And from the axillary artery, you get ramifying branches which are entering the. Those are called as perforator breast. Lymphatic drainage is very important. Is it clear? You can divide the breast into 4 quadrants: upper lateral, upper medial, lower medial, lower lateral. Is it clear? And the lymph nodes are. What is this bone? Clavicle. So this area, upper part, upper medial part will go to infraclavicular group of lymph nodes. Infraclavicular group of lymph nodes. So clear? Lymph nodes, not lymph vessel. We'll come to the lymph vessel later. Lymph node. Next is apical, central, lateral. So clear? Apical, central, lateral. This area will come to central. This go. Sorry, this is apical. This is lateral. Shall I repeat once again? Yes. Apical, lateral, central. CLA. Already what we finished? Infraclavicular group of lymph nodes. So this area, right, this lateral quadrant, lower lateral part will come to the lateral aspect. Lateral will come to the central aspect. Lymph from all the, wherever it has been drained, finally it will go to apical group of lymph node. Final drainage is apical. I said apical is related to which structure? Axillary tail of Spence. It is related to axillary tail of Spence. This is our the area, the ectodermal milk ridge. The ectodermal milk ridge. Breast is developed from the ectodermal milk ridge. So these are the ectopic sites of breast. Normally, breast is present on the pectoral region. Apart from this, this ridge will disappear. Sometimes the female can have supernumerary breast as additional sites. I said lymph node. I didn't tell about you the lymph vessel. There are two lymph vessels on the breast. One is superficial lymph. Other one is the deep one. Superficial and deep. Superficial and deep. The superficial will drain the skin of the breast except nipple and areola. Deep lymph vessel will drain whole of the breast. You understand? There are two types of lymph. Superficial and deep. Superficial and deep. The superficial will drain the skin of the breast except nipple and areola. Nipple and areola is a part of the skin, am I right? So it is deep will drain rest of the part of the breast. Part of deep superficial lymph will drain rest of the part of the breast. Only two lymph vessels you have to remember. Next is the supraclavicular lymph of groove node. If it is enlarged, that is called as Virchow node. It is otherwise called as supraclavicular group of lymph nodes, which is otherwise called Virchow group of, which is enlarged on CA breast. And this cutaneous we already completed. I think this I can skip. Am I right? This is C4, C5, C6, C7, C8, D2. It's very easy, am I right? Shall I proceed with the next one? Next, what is groove? Pectoral groove. What is this muscle? Pectoralis major. This muscle is deltoid. Absence of the pectoralis major muscle can occur. That syndrome is called as Poland syndrome. Am I right? Here you cannot find the pectoralis major. Am I right? Here you can see it. Again, you remember the nerve which are piercing the pectoralis major is medial pectoral and lateral pectoral nerve. Lateral pectoral nerve. What is this muscle? Pectoralis major was inserted on the coracoid process of this process is called coracoid process of scapula. It arises from the upper third, fourth, fifth rib. This is first rib. This is second rib. It arises from 3, 4, and 5 instead on process. This picture tells you the nerves which are piercing major medial pectoral nerve. This is lateral pectoral nerve. This is medial pectoral nerve. Medial and lateral pectoral nerve. The fascia that is present deep to the cut end of the pectoralis major. If you cut the pectoralis major, there is a fascia inside the pectoralis major called as clavipectoral fascia. Clavipectoral fascia, which is pierced by, what is this vein which is piercing it? Cephalic vein. The vein is cephalic vein. Again, there is one more artery piercing it. It is thoracoacromial artery. Thoracoacromial artery. And there is one more nerve, medial pectoral nerve. So, how many structure pierces clavipectoral fascia? 3 structure pierces clavipectoral fascia. 3 structure pierces clavipectoral fascia. Again, you see arrangement of the clavipectoral fascia. This smaller area. It is enclosing above what muscle? It is enclosing subclavius muscle. Below it is enclosing pectoralis minor, not major. Major. It is enclosing how many muscle? Muscle. One muscle above is subclavius. The muscle below is pectoralis minor. It is structure. What is this? Deltoid, which is inside of tuberosity of humerus. Deltoid tuberosity of humerus. Now you see on the picture arrangement of it. Here you multipinnate. This is unipinnate, right? It contains 3 types of fibers. center fiber. This is the center fiber. This is anterior fiber. This is posterior fiber. Anterior and posterior fibers are unipinnate. What is present on the center is bipinnate. It is bipinnate. The rounded shoulder nature of the deltoid is due to, of the shoulder is due to deltoid. It is supplied by axillary nerve. What would be the function? Initiation of, what is this action of the, this is adduction, this is abduction. So abduction is initiated by, so main prime action of deltoid is abduction of arm supplied by axillary nerve, which is used clinically for intramuscular injection. Where you have to give, it is on the upper lateral part, the intramuscular injection is given off. Is it clear? Not close towards the insertion, it is on below the origin on the upper lateral quadrant of the deltoid. Next is axilla. What is axilla? Axilla is arm print. This can you able to see this? A truncated one. This area. Right? So what is this? This is the anterior wall. This should be the posterior wall. This should be a floor. The contents is inside. Apex is pointed towards the clavicle. Apex, base, anterior wall, posterior wall. You understand, right? Now anterior inlet. Inlet is the apex. Whatever on the neck come to the axilla, then it should come to the upper lip. Am I right? Main is brachial plexus. So they enter through the inlet of the axilla, which is called as cervico-axillary canal. That canal is called as cervico-axillary canal. See on the picture, it is bounded anteriorly by clavicle, posteriorly by scapula, medially by first rib. This small interval is called as cervico-axillary canal. Cervico-axillary canal. Cervico-axillary canal, which transmits the structures from the neck in the cervical plexus. That is the inlet of the inlet. This area is the inlet. This is the base. Anterior wall. Posterior is posterior, medial, lateral. Anterior wall is formed by what muscle? See the picture. Pectoralis major. Posterior wall is formed by, it has been already marked. Subscapularis, teres major, latissimus dorsi. This is medial wall. Am I right? Anterior, posterior, apex, base, medial wall, lateral wall. Lateral is nothing but what bone? Humerus. If you adduct, it absolutely forms the wall of the axilla. If you abduct, the wall is not defined. Am I right? So laterally it is formed by what bone? Humerus. Medially, what is this area? Rib cage. What muscle you expect here? Lateral aspect. Anteriorly pectoralis major. Laterally serratus anterior. Am I right? Which leads to winging of scapula. Am I right? Which is on the lateral surface of the rib. Anteriorly pectoralis major. Laterally it is serratus anterior, which is supplied by long thoracic nerve. Long thoracic nerve. Lateral wall is formed by what bone? Humerus, and the content are trunks of brachial plexus, axillary. Is it clear? Next is brachial plexus. Brachial plexus. Can I draw on an empty slide? That would be more fun, I think. கூப்பிடுறீங்க நியூ ஸ்லைட் எப்படி வைக்கணும்னு எனக்கு தெரியல. இல்ல யாரோ ஒருத்தர் கூப்பிடுங்க. I'll draw very briefly. From that, we'll finish whole of the, more or less, the upper limb will be completed on the brachial plexus self. Okay, this is very important. This will take some 5 minutes. Then remaining things, new slide code. இதுல நான் எக்ஸ்ட்ரா வரையணும்னா எப்படி வரைய? இதுலயே தான் பண்ண முடியுமா இல்ல எம்டி பேஜ் கிடைக்குமா? டிஸ்டர்ப் பண்ண வேண்டாம்னா விட்டுறலாம். இது எத்தனை ஸ்லைடு? இது 49 ஸ்லைடு. சரி முடியாதுன்னா பரவாயில்லை. அந்த ஸ்லைடு நான் லாஸ்ட்ல நியூ ஸ்லைட் போட முடியுமான்னு பாக்கிறதுக்காக போனேன். சரி, ஓகே. வரல. இதுல வந்துரும். Remember, the plexus is formed by the ventral rami. Okay, so whenever we read spinal nerve, it has a ventral rami and dorsal. What is coming anterior is ventral, what is going posterior is dorsal rami. Okay, so this is root of brachial plexus. This is the trunk of brachial plexus. This is division. This is cord. This is branches. Okay, so C5, C6, C7, C8, C9. Sorry, T1. The root of C5, C6 form a trunk. The root of C7 form trunk. The root of C8, T1 form lower trunk. Upper trunk, middle trunk, lower trunk. Each trunk divides into anterior division and posterior division. Anterior and posterior. The anterior division of upper and middle unite to form lateral cord. You understand? This is anterior, this is posterior. Anterior, posterior. Anterior, posterior. Anterior of upper and middle unite to form lateral cord. Anterior of, what is this? Lower trunk forms medial cord. What is remaining? All posterior. All posterior form lateral, medial, posterior cord. This gives off 5 branches. This gives off lateral cord 3 branches. Medial cord gives off 5 branches. It will give off 5 branches. I said this C5, C7, T1, C5, C6 unite to form upper trunk, C7 form middle trunk, C8, T1 form. Each trunk divides into anterior division and posterior division. Anterior of upper and middle form lateral cord. Anterior of middle forms posterior cord. Okay. Now lateral cord gives off 3 branches. Medial cord gives off 5 branches. Posterior cord gives off. Remember, for cord ulnar nerve, axillary nerve, nerve to latissimus dorsi, nerve, cutaneous nerve of arm, and musculocutaneous nerve. Later, concentrate on the picture alone. I said, what is this part? 3 cords. They are in relation with which artery? Axillary artery. First part of axillary artery, right? Medial cord is anterior or posterior? This is first part of axillary artery. First part of axillary. We'll finish the relation here itself. To the first part of the axillary artery, medial cord is posterior. Late posterior cord is medial. Posterior cord, sorry, medial cord is normally posterior cord na pinadi irukku nama nenippom, right? It is not so. It is lateral posterior on the first part of axillary artery. If you take the second part, lateral cord is lateral, posterior cord is posterior, medial cord is medial. So you get rotation. This relation difference you should remember. What is the relation of the cords with the axillary artery? Update the axillary artery oda the first part, the second part. Vice versa, you have to read for brachial plexus and axillary artery. This I won't repeat again in axillary artery. Okay. For the second part of axillary artery, what is medial? Medial cord of brachial plexus. What is posterior? Posterior cord. What is lateral? Lateral cord. What is innervating between the axillary artery and axillary vein? Medial cord. These are all MCQs. Third part of axillary artery. First part, second part, third part. Axillary artery is divided into how many parts? 3 parts. Subclavian artery continues as axillary artery. Axillary artery continues as brachial artery. Brachial artery bifurcate at the level of neck of radius on the cubital fossa as brachial artery laterally and ulnar artery medially. Ulnar artery continues as superficial palmar arch. Radial artery continues as deep palmar arch. This is the architecture of the arteries present on the upper limb. So now you see the cords are related. Only the branches of the brachial plexus are related to the third part of axillary artery. Cord relation is very important for MCQ. First part and second part. What is Erb's point? This is C5. This is C6. Nerve arising from C5 is nerve to rhomboids. Nerve to rhomboids. C5, C6, C7 unite to form long thoracic nerve of Bell, which is going to supply serratus anterior nerve of Bell, which is the reason for winging of scapula. Two nerve arises from this upper trunk. This is anterior division and posterior division. Nerve to subclavius and suprascapular nerve. Suprascapular nerve. So, Erb's point is nothing but meeting of nerves. Root of C5 and C6. Am I right? Suprascapular nerve. Nerve to subclavius. Anterior and posterior division of upper trunk. Am I right? This is first one. This is second one. 3, 4, 5, 6. So 6 nerves meets on the upper trunk of the brachial plexus, that is called as Erb's point. If there is any injury, that is called Erb's. This is the picture how the child is. That deformity is called as Pollich's hand deformity. During abnormal labor, during birth injury, this can occur. Klumpke's paralysis, where you get flexion of fingers. Here the fiber involved is C8 and T1 of brachial plexus. C8 and T1. If T1 is involved, what would be the additional feature? It is harness syndrome. Apart from this is claw hand. Am I right? C8 is claw hand. Additionally, due to the involvement of T1, it is harness syndrome. So this is the feature of paralysis, and you should know which nerve is involved on Erb's paralysis, which nerve is involved on Klumpke's paralysis. Next is intramuscular spaces. What are all spaces? This quadrangular space, upper triangular, lower triangular. Quadrangular space is formed by teres minor above, teres major below, rest, long head of triceps, long head of triceps. Lower triangular space is formed by, this is long head of, this muscle is long head of triceps, right? This is full of long head of triceps. What we are now reading is upper triangular space. Okay, upper triangular space. This is teres major, teres major. This is teres minor. This is long head of triceps. So upper triangular space is bounded by teres minor, teres major, long head of tricep. This is upper triangular. Lower triangular is formed by inverted triangle. Teres major, long head of triceps, of Shaft of humerus. You understand, right? The content are the lower triangular space contain radial nerve and profunda brachii artery. Radial nerve and profunda brachii artery. This is the radial nerve and profunda brachii artery. Quadrangular space contain axillary nerve and circumflex, anterior and posterior circumflex artery. All theory you have to remember, no other option. The content of, you should know the boundary, what are all the content. And the upper triangular space contains circumflex scapular artery. Circumflex scapular artery. So clear, this is given on your text part, you have to read this. There are some spaces within the muscles of the upper limb called as intermuscular spaces. The important muscle of the arm, biceps. The muscle is biceps. The peculiar feature is it is capsular. What is it? Capsular? It arises deep to the shoulder joint. So it pierces the capsule, then it comes out. So it is called intracapsular, which is inserted by bicipital aponeurosis on which bone? On the radius. The insertion is on radius. What is the main action of biceps? This compartment is flexor compartment, but the main action is supination. Strong supinator is the strong supinator of the forearm. Strong supinator. So it is not supinator. Though we have supinator muscle, strong supinator is biceps. Next muscle is tricep, which has 3 heads, which is inserted on the olecranon process. Anterior compartment, the nerve is musculocutaneous nerve. Posterior compartment, the nerve is radial nerve. Posterior compartment, it is radial nerve. All the muscles of anterior compartment, musculocutaneous nerve, which arises from the lateral cord of brachial plexus. After supplying this 3 muscle, it is a motor nerve, am I right? But it continues as the lateral cutaneous nerve of forearm, which is sensory. You understand, right? Musculocutaneous nerve arises from the lateral cord of brachial plexus. Lateral cord, 3 branches, 1 branch is musculocutaneous nerve. After supplying 3 muscles of the arm, biceps, coracobrachialis and brachialis, it continues as, it comes out of the muscle, comes to the skin as a cutaneous nerve called as lateral cutaneous nerve of forearm. So what are all the 2 veins of the upper limbs on the skin? It is present. Here it is cephalic vein, here it is basilic vein. The vein that is present on the lateral border of the arm is cephalic vein. Here it is basilic vein. So what nerve I said now? Lateral cutaneous nerve of forearm. So lateral cutaneous nerve of forearm is accompanied by what vein on the forearm? Cephalic vein. So here 2 structures are present on the skin of the forearm. One is lateral cutaneous nerve of forearm, and so that lateral cutaneous nerve of forearm is nothing but musculocutaneous nerve. Next is cubital fossa, a triangle in front of the elbow, which is bounded by pronata teres and brachioradialis. Brachialis. It is brachialis. The content of the cubital fossa are, what is this nerve? First nerve. Content. It is median nerve. It is median nerve, and the termination of brachial artery into ulnar and radial artery. Next is the tendon of biceps. Tendon of biceps. 3 structures forms the content of cubital fossa. See, this is the cubital fossa. Am I right? First layer is skin. If you peel off the skin, you get the cubital fascia. I already told you the lateral vein is cephalic vein, the medial vein is basilic vein. On the cubital fossa, there is one more vein on the center. It is median cubital vein on the superficial fascia, right? Where we take intravenous injection, right? Vein is in median cubital vein. Median cubital vein, which is connecting the cephalic and basilic at the level of the elbow. The content of the cubital fossa are median nerve, termination of brachial artery, and the tendon of biceps. Tendon of biceps. The boundary is medially it is formed by pronata teres. Laterally it is formed by brachialis. It is formed by brachialis. Next is anterior compartment of the arm. It is divided into superficial layer and a deep layer. Superficial layer 5 muscle, deep layer 3 muscle. All 5 muscle take origin from common flexor origin, which is nothing but the medial epicondyle of humerus. All the 5 superficial muscles of flexor compartment of forearm arises by a common origin, medial epicondyle of humerus. The muscles are pronator, flexor carpi radialis, palmaris longus, flexor carpi radialis. Okay. What you have to remember is these are the deep muscle. See all the muscle, flexor, pollicis, and digitorum. Pollicis towards thumb finger. Other 4 are coming towards the other fingers. Thumb you have separate fiber. This muscle is pronator quadratus, which is connecting radius and ulna on superior aspect or inferior aspect. Inferior aspect. Pronator quadratus. Pronator quadratus. I said flexor digitorum profundus. Am I right? The tendon what is going towards the thumb finger is flexor pollicis longus. The facial lead surrounding that thumb finger is called as radial bursa. All other 4 fingers have common fibers. Am I right? Flexor digitorum profundus. That is covered by a facial sling called ulnar bursa. What is radial bursa? In the flexor digitorum profundus. What is covered by one muscle on the pollicis is radial bursa. Next, cubital tunnel. Cubital tunnel. What is present behind? I said ulnar nerve is related to the medial epicondyle behind. Right? So that tunnel is called as cubital tunnel. It enters the forearm. Ulnar nerve should come to the forearm. Am I right? It comes to the forearm by passing through the 2 heads of flexor carpi ulnaris. Pronator teres enters the median nerve by passing between the 2 heads of pronator teres. These are all important. Median nerve enters through 2 heads of pronator teres. Ulnar nerve enters between 2 heads of flexor carpi ulnaris muscle. Flexor carpi ulnaris. Median nerve it enters between 2 heads of pronator teres. Is it clear? Only radial nerve will end at the level of the elbow. At this level, it divides into a superficial branch and deep branch. Is it clear? Superficial branch is cutaneous. Superficial branch is cutaneous. It supplies the skin of the dorsum of the hand. This area is supplied by what nerve? Superficial branch of radial nerve. Superficial branch of radial nerve. Anterior compartment of the arm is supplied by what nerve? Musculocutaneous nerve. Posterior compartment of the arm is supplied by radial nerve. Now we trace how many nerves? 2 nerves. Ulnar and median. Radial will come to. We are discussing anterior part, right? Radial at this level we are stopped. It supplies what muscle? It supplies what muscle? What is the muscle here? Triceps. Posterior compartment triceps. I said how many muscles on the superficial plane? 5 muscles. How many muscles on the deep plane? 3 muscles. On the superficial plane, the lateral 4 muscles are supplied by median nerve, except flexor carpi ulnaris is supplied by which nerve? Ulnar. Namely, flexor carpi ulnaris is supplied by ulnar. Now, how many muscles on superficial plane? 5 muscles. 4 muscles are supplied by median nerve. Muscle is supplied by ulnar nerve. On the deep plane, how many muscle I said? 1, 2, and 3. Am I right? On the deep plane, pronator quadratus, flexor pollicis longus is supplied by again median nerve. The name of the nerve, one nerve rises from median nerve. What is the fibrous sheath which is covering the ulna and radius? What is connecting here is interosseous membrane. Interosseous membrane will hold the radius and ulna. So a branch called anterior interosseous nerve arises from median nerve in front of the elbow. That supplies flexor pollicis longus, pronator quadratus, and lateral half of flexor digitorum profundus. Lateral half of flexor digitorum. It represents what is pending. Only lateral half I am telling. So which half is pending? Medial half. You divide the muscle into two. What is going towards this two little finger? This two fingers is lateral. This is medial. These two fibers are supplied by anterior interosseous nerve. This is pending. Am I right? Which is supplied by ulnar nerve. You understand, right? So ulnar nerve supplies 1.5 muscle. Superficial compartment, flexor carpi ulnaris. On the deep plane, medial half of flexor digitorum profundus. Remaining all the muscles of the forearm are supplied by ulnar nerve. To be specific, deeper plane, 2.5 muscle is supplied by anterior interosseous nerve. Anterior interosseous nerve, which is a branch of median nerve. So if there is an anterior interosseous nerve, there should be a posterior interosseous nerve. We ended radial nerve at this side, am I right? Which is divided into superficial branch ending on dorsum of the hand. What is this compartment of the forearm? Otherwise called as extensor compartment. So all the muscle of the extensor compartment are supplied by radial nerve. Be specific. Posterior interosseous nerve. Radial nerve is itself. All the muscles of the extensor compartment are posterior interosseous nerve. Radial nerve on the arm we'll discuss. Up to this clear, am I right? How many layers on the flexor compartment? 2 layers, superficial layer and deep layer. Superficial layer, how many muscle? 5 muscle. Deeper layer, 3 muscle. Of the superficial, 4 muscle are supplied by median nerve. One flexor carpi ulnaris is supplied by ulnar. Deep muscle, how many muscle? 3 muscle. So ulnar nerve in general supplies how many muscle of 8? 1.5 muscle. Remaining muscles are supplied by median nerve and its branches. Okay. I'll show the picture alone so that we can skip off fastly. Okay. The sheath which is present in front of the wrist is called as flexor retinaculum. Am I right? You said carpal bone, right? She looked too pretty. Am I right? Try to catch her. Leave all those things. She is this is lateral, this is medial. What is this? Scaphoid, pisiform, trapezium, hamid. H. Am I right? தெரியலையா இங்க மாறிடுச்சு எனக்கு நெட் ஸ்லோவா இருக்கு போல இங்க மாறுது அங்க மாறலையே இங்க சேஞ்ச் ஆகுது இதுல சேஞ்ச் ஆகல லேப்டாப்ல ஹேங் ஆயிடுச்சு so flexor compartment right what is this bone you expect here she look too pretty count the bone alone on the proximal row on the both margins she look too pretty try her catch her right you connect all bones by fiber sheet is the attachment of flexor right you have 8 bones only the corner bone of each proximal row distal row you recollect connected by a fibrous band that is the attachment of flexor retinaculum I said so many tendons are coming flexor digitorum all those tendons passes deep to flexor retinaculum except only one fiber which is palmaris longus which passes superficial to flexor retinaculum. It forms a sheath on the end of aponeurosis, like plantar aponeurosis on your foot. Here it is called as palmar aponeurosis. So what is the structure present deep to the flexor retinaculum is all the flexor tendons, and one nerve you remember it is median nerve. Ulnar nerve passes superficial. I said two nerves, right? Ulnar nerve is superficial, median nerve is deep. Is it clear? Ulnar nerve is deep, median is deep, ulnar is superficial, along with ulnar artery. So structure passing deep to retinaculum, structure passing superficial to retinaculum. So what is the retinaculum you expect here? Here it is flexor, so here it should be extensor. What is this bone? Lateral bone of the forearm is radius. This is lower end. Extensor retinaculum. I'll show the picture. Time being, it's very easy when you read on your own hand, rather than this type of, only for picture question it will be useful, rather than to understand the theory. This is lower end of radius. Lower end of the radius. Put an oblique cut towards the, again the medial bone of the towards the carpal bone. So that is the attachment of extensor retinaculum, which is divided into 6 segments. It has 6 compartments. Each compartment will transmit some structures. What is this fossa called as? Not scaphoid fossa. Anatomical snuff box. See on the picture, we'll finish off this soon. This is flexor retinaculum. This is palmar aponeurosis. This is the median nerve, which is passing deep to the retinaculum, and ulnar nerve and ulnar artery, which is superficial. What is this? Palmar is longest, which is forming superficially. What is this aponeurosis? Palmar aponeurosis. That contraction occurs on the palmar aponeurosis is called as Walmach ischemic contraction. If it is a rupture, that condition is called as Walmach ischemic contraction. I said how many segments? On the extensor retinaculum, 6. This you have to memorize. No other option. பொறுமையா உட்கார்ந்து இந்த ஸ்லைடு பார்த்து ஒரு compartmentல என்னென்ன போகுதுன்னு படிக்கணும் நீங்க. Additionally, what is missing on this is 4th compartment transmits posterior interosseous nerve and anterior interosseous artery. There are 4 stuck. This is very, very important. 4th compartment is important. I said radial nerve ends at which level? What is the deep branch called as? Posterior interosseous nerve. That is present on which compartment? 4th compartment. It ends as a pseudo ganglion at the level of the wrist. Radial nerve will not extend beyond the wrist to the fingers and all. Only median nerve will supply the hand muscle. So it ends as, radial nerve ends as how? Pseudo ganglion. This is important. 4th compartment structure you have to memorize. Okay, extensor retinaculum. So I completed 2 retinaculum. Short muscles of the hand. Am I right? There are 20 muscles on the hand. This eminence is thenar eminence, 4 muscle. This eminence is hypothenar eminence. And there is one more muscle, subcutaneous muscle of the hand is palmaris brevis. What is the subcutaneous hand? Only one subcutaneous muscle is palmaris brevis, which is present on the medial side of the hand. Now you see on the picture, first lumbrical and second lumbrical are unipinnate. Third lumbrical and fourth lumbrical are bipinnate. These are all important. First lumbrical and second lumbrical are unipinnate. Third and fourth are bipinnate. They arise from the tendon of flexor digitorum profundus. All are supplied by ulnar nerve. 3 palmar interossei. Am I right? Interossei. What is present between the phalanx is called as interossei muscle. Totally 7 interossei. What is present on the palmar aspect is 3. The function is, these are all important MCQ. In the slide irukadha appadiye padikkanum. Main action is adduction supplied by ulnar nerve. Already how many muscles are supplied by ulnar nerve? Idukku munadi hand la. Previous one. 4 lumbricals. 3 interossei. I said 20 muscle. Am I right? So far how many muscle completed? 7. 4 plus 3 is 7. Dorsal interosseous. தெரியுதா 1 2 3 4 இருக்கா 4 plus 4 plus 3 11. Palmaris brevis, how many? Add one more. It is a subcutaneous muscle present deep to the skin. And what is this area? Hypothenar. So I'll compile the distribution of ulnar nerve on the hand. One subcutaneous muscle, palmaris brevis. 3 hypothenar muscle, lumbricals, interosseous, both dorsal and palmar. 7. All are supplied by ulnar nerve. Hypothenar eminence is supplied by median. You understand, right? Now you know the supply of median nerve on the forearm. Am I right? Median nerve supply, ulnar nerve supplies 1.5 muscle out of 8. Remaining 6.5 is supplied by median nerve. Deep muscle is 3. 2.5 is supplied by anterior interosseous nerve. On the hand, all the muscle, thenar eminence is supplied by median nerve. All other muscles are supplied by ulnar nerve. Lumbricals, you should know which is bipinnate, which is unipinnate, that you read from the PowerPoint. Slowly you sit off. If the fibers are arranged like this, these are all bipinnate. These are all unipinnate. இப்படி bone இருக்கு ரெண்டு பக்கமும் fiber இருந்துச்சுனா bipinnate. If you have only one type of fiber, it is unipinnate. Okay, this will compile, right? This is very important. This is lower triangular space. Lower triangular space. What is the content of lower triangular space? Radial nerve and profunda brachii artery. Radial nerve, how it is formed? All the posterior cord unite to form which cord? All the posterior division unite to form posterior cord. Posterior cord gives how many branches? 5 branches. Ulnar, you remember. This R is radial nerve. So radial nerve arises from which cord? Posterior cord. Posterior cord of brachial plexus. So you get from C5 to T1 from all the part of the brachial plexus. What is clinically important is, I said spiral groove on the posterior surface, right? How many heads for triceps? Tri is 3. Long head and medial head. Again, lateral head and medial head. This is above the spiral. You can divide the humerus above the spiral groove and below the spiral groove. If this is the spiral groove, you remember this is the spiral groove. Say for example, 2 nerves arises above the spiral groove. Long head and medial head is above the spiral groove. On the spiral groove, lateral head and medial head. So medial head has how many supply? 2 supply. Am I right? So if there is a fracture of humerus, which head can be involved? Lateral head is involved. Medial head escapes from paralysis due to the supply of median nerve from the above. You understand, right? Since it is dual supply, one from above, spiral groove is fractured, but I am getting one more supply additionally from the above source, so I am not involved. And unconeus is muscle present at this side. I'll show on the picture. But the nerve to unconeus arises from the spiral groove. Unconeus is somewhere over here, but the nerve supply is from the spiral groove. It is the muscle of extensor compartment of the forearm. So you get a paralysis of unconeus. You cannot extend the forearm. So nerve to unconeus, these are important. Nerve to unconeus arises at which side? On radial groove. Medial head has how many nerve supply? 2 head. One above, one on the spiral groove. We already finished, right? Posterior interosseous nerve, how it ends? Pseudo ganglion. Superficial branch, where it supplies? Dorsum of, see this? Dorsal of the radial nerve. Can you able to see this one? Thus supplying the skin over the dorsum of the hand. This is important, right? Up to this area only, it is radial nerve. Remaining thumb finger, next step. Middle finger, little finger, and up to this area, it is supplied by median nerve territory. Little finger and the ring finger, ulnar nerve. With this picture, you have to remember the on the dorsum of hand. Dorsum of hand, cutaneous nerve supply. This is very important. பொறுமையா உட்கார்ந்து இந்த டயகிராம் வரைஞ்சு படிக்கணும் சரியா ஒரு 2-3 minutes கூட ஆகாது. Spend some 2 minutes this picture. You have to memorize the cutaneous innervation of the hand. So paralysis causes wrist drop if the ulna and the median nerve is in. Axillary nerve is ending on which muscle? What is this muscle? Deltoid. Which is the content of what is this triangle? Quadrangular space. Along with anterior and posterior circumflex, humeral artery, which are all branches of brachial artery. Okay. If there is, what is this site of the arm? Lateral part, right? So here it is supplied by lateral. Remember, upper part, lower part. Upper part is from axillary nerve, lower part is from radial nerve. So if this area doesn't have cutaneous innervation, that represents which nerve is involved? Axillary nerve. Lateral upper part of arm, lower lateral part of the arm. Lateral upper part of the arm is supplied from branch from axillary nerve. Lower part is from radial nerve. Here again, lateral cutaneous nerve of forearm is the continuation of musculocutaneous nerve. Up again, what should be the nerve here? Medial cutaneous nerve of forearm, which arises from the medial cord of brachial plexus. For the medial side of the forearm, it is directly from brachial plexus. Only to the lateral part of the forearm, it is arising from the musculocutaneous nerve. You understand, right? We are talking the cutaneous innervation. This is important clinically. That's the reason why I am telling again and again. Ulnar nerve enters between two heads of flexor carpi ulnaris. What you should remember is, I'll tell you. Ulnar nerve distribution on the, this is palmar aspect, this is the dorsal aspect. Ulnar nerve supplies how many fingers? 1.5 fingers. Here it is 3.5 fingers. Over here, ulnar nerve. Again, 1.5 fingers. So ulnar nerve is coming to the wrist. It is passing superficial or deep to retinaculum? It is passing superficial to the retinaculum. It ends on the hand by supplying all the muscle, right? That we finished already, you know, right? It is supplying the palmar brevis, hypothenar eminence, lumbricals and interosseous. Median nerve enters. Ulnar nerve is otherwise called musician's nerve. Median nerve is otherwise called labrador's nerve. It is otherwise called labrador's nerve, right? So median nerve arises by how many roots? 2 roots. I said lateral cord and medial cord. Both the cord will contribute to the formation of median nerve. So this is which region? Axilla. Now you see this is median nerve. What is this artery on the center? On the forearm, what is the artery? Brachial artery. Now you see on the picture, the median nerve is lateral to the artery in the upper part. It crosses the artery on the center. Then it comes to the medial side of the artery in the lower part. Am I right? So triplet relation of median nerve to the brachial artery. To the brachial artery upper part lateral. On the center it is crossing. Here it is medial. Now median nerve passes between the two heads of which muscle? It is the content of which fossa? As we already discussed. Cubital fossa. Median nerve, brachial artery termination, tendon of biceps. It enters between the two heads of pronator teres. Ulnar nerve enters between the two heads of flexor carpi ulnaris. It passes deep to retinaculum or superficial to retinaculum. Superficial to retinaculum. Again, it supplies the muscles on the hand. This you have to remember, right? Sometimes a bony projection arises from the lower end of the humerus towards the medial epicondyle, which is connected by a fibrous sheath that is called suprascondylar spur, otherwise called Such's lig. If it is present, the brachial artery and median nerve will go through this. Thereby, neurovascular compression will be present. It doesn't take its normal course. That is the importance of knowing this. What is supracondylar spur? Arteries of the upper limb, right? Axillary artery continues as brachial artery continues as radial and ulnar. Branches of axillary artery. It is divided into how many parts? 3 parts. First part, second part, third part. A muscle divides this called as pectoralis minor. Pectoralis minor divides the axillary artery into how many parts? 3 parts. First is superior thoracic artery. First part it is superior thoracic artery. Second part lateral thoracic and thoracoacromial artery. From third part subscapular, anterior circumflex, posterior circumflex. Totally 6 branches are given off from axillary artery. Axillary artery continues downwards as brachial artery on arm. Single lumen continuing different places, different names. Teres major muscle will be present. It extends from teres major muscle to the neck of radius. That is the extent of which artery? Lower border of teres minor muscle to the neck of radius is the extent of brachial artery. Ulnar artery continues as, what is this one? Superficial palmar arch. Radial artery continues as deep palmar arch. What is the vein present here? Cephalic vein. Here the vein is basilic vein. What is the importance of radial artery? Radial artery importance. Palpation of pulse. Now you concentrate on anatomical snuff box. This tendon is flexor pollicis longus. Sorry, extensor pollicis longus. There are 2 more tendons, extensor pollicis brevis and abductor pollicis. The content is radial artery. The content is radial artery. Deep to it, lunate bone is present. Lunate. The bone present deep is lunate, which is common for dislocation. Remember, scaphoid is common for fracture. Lunate is common for dislocation. This is important again. Scaphoid is fracture. Common fracture of wrist is scaphoid. Common dislocation is lunate. I think I'm so fast. Am I right? A dorsal venous arch corresponding to the arteries. Deep veins are present. Superficial vein is important. Here it is dorsal venous arch. It continues laterally as cephalic vein, basilic vein as medially. What is the vein connecting basilic and cephalic on the in front of cubital fossa? Median cubital vein. Cephalic vein will pierce what fascia here? Clavipectoral fascia. It drains into axillary vein. This is a cephalic vein which is draining on the axillary vein. Can you able to see this? What is this vein? Median cubital vein, cephalic vein, deltopectoral groove ending on the axillary vein. Right? Can you able to see this? Already we finished. Only picture I didn't show you. This is what is this vein? Median cubital vein. This is basilic vein. This is cephalic vein. Radiographic pictures. Right, this is the shoulder joint AP view. Shoulder joint, plain X-ray, shoulder joint AP view. You get trans-opaque shadow and translucent shadow on an X-ray, right? This is trans-opaque. Being bony structures, these are trans-opaque shadows. Trans-opaque shadows, right? You can see the bony structures. You have to just know what are all the trans-opaque shadows that are present normally. Okay, there is no superimposition. Scapula is anterior or posterior to us? Scapula is behind, but you can see the outline of the scapula. So it is a superimposing structure on the normal X-ray of the shoulder joint. Likewise, this is the X-ray of elbow. But this angle already I told you, am I right? Angle between the arm and forearm is called as carrying angle. This is the X-ray of wrist. 8 bones you should be able to appreciate on the picture. Okay. Colles fracture is the fracture of lower end of radius. The deformity is dinner fork deformity. One case we'll discuss. A 29-year-old man comes in a stab wound injury, cannot raise his arm above horizontal and exhibits a condition known as winging of scapula. What is the muscle involved in winging of scapula? Serratus anterior. Nerve to serratus anterior arises from medial cord, posterior cord, lower trunk, root, upper trunk. Upper trunk. C5, C6, C7, right? It is root, ma. It arises from root, right? C5, C6, C7 root lende vandrom. Liya, in anterior division, posterior division la. So it is root. A 22-year-old patient received a stab wound which is that is intracostobrachial nerve is nothing but T2 fiber. Okay, T2 is intracostobrachial nerve. Which of the following results from the described lesion? Enga sensation irukadu. This is the answer. The answer is D. Because T2 supplies, okay, T2 is second intercostal space. That nerve is supplying intercostal space as well as the medial part of the arm. Okay, so you get communication between the upper limb and thorax. So that is the intercostobrachial nerve. That's the reason the question is asked. It is supplying intercostobrachial, interconnecting costobrachium is arm. It is connecting both arm and the brachium. So it is intercostobrachial nerve. Last case, one more case. You have case questions or not? Do you have case question for the exam? Yes. Okay. A patient complains of only thing you have to strong enough in gross anatomy. You can correlate which region it is. You can come to the diagnosis very easily. Okay. A patient complains of having pain with repeated movements of his thumb. Repeated movements is opponent's polysis, right? The thumb finger is touching all other fingers. Am I right? This is the unique feature of man. Am I right? For the monkey ape, it is like this, right? It doesn't have one muscle. Opponent's polysis is absent on monkey. We have that muscle. That's the reason why we can touch the other fingers. No other finger can touch each other. Am I right? Only thumb can go and touch all other fingers. It is because of opponent's polysis. His physician performs Allen's test with the help of the pen and finds an insufficiency of the radial artery. Which of the following condition would be a result of the radial artery stenosis? Marked increase in blood flow in superficial palmar arch. Superficial palmar arch is formed by ulnar artery, which is completed by radial artery. Decreased pulsation in the artery passing superficial to the flexor retinaculum. Ischemia of entire muscle. Marked decrease in blood flow. So what would be the answer? Answer is D. Marked increase in princeps pollicis artery. Okay, it is a branch of radial artery. Okay, 5 minutes. We'll take a break. With this, I'm completing upper limb. We'll do thorax. Okay, it's very brief introduction. Go through the PPT. Any clarification, day after tomorrow, I'll come. We'll have a session for 10 to 15 minutes for clarification of the doubts. Okay, if you want how to read, where to read, come with your textbooks. We can discuss it. Okay. You want break, right? 5 minutes? Yes.